So prior to 2016, there was a 30-year period in bladder cancer where there was one drug approved by the FDA, and it was intravesical valrubicin, which isn't really used that often. So really quite a dry spell for a long time. This all changed in 2016 with the introduction of immune checkpoint blockade. 5 drugs approved between 2016 and 2017. And this has been transformative for the disease, but unfortunately these drugs only work in a subset of patients, and we need new options. There's clearly been a collateral benefit, though, of immune checkpoint blockade, even to patients who don't respond to treatment, and that is shown here. These are the trials that are currently accruing in bladder cancer on clinicaltrials.gov, and there really has been a resurgence of interest in this disease, I think mostly stimulated by the success of immune checkpoint blockade, which has really led to a likely benefit in the future to all patients. So there's 200 studies enrolling patients right now and seeking to enroll 40,000 patients with bladder cancer. And to put that into some context, the incidence of bladder cancer in the United States each year is about 80,000. We know that the majority of patients present with non-muscle invasive disease. So the pendulum has really swung here, and there's starting to be more slots for trials than there are patients, and we really need to think a little bit more carefully about how we set priorities for treatments. And this really leads to the theoretical question, or the philosophical question. Where should we find drugs for bladder cancer? Should we take drugs that work in other diseases and just apply them in this disease? Or should we really focus on bladder cancer specific biology? And I don't pretend to have the answer to this question, and I'm not placing a value judgment on either of these because I'm a pragmatist, and I think most of what we've been successful with is actually this. But we're supposed to be having an academic discussion here, and so certainly this is the focus. So in just 10 minutes, I'm not going to be able to cover all the targets that are of interest, and I should mention that talking about bladder cancer specific biology is certainly different than talking about targets that are present in bladder cancer. I'm not sure we're really ready to tackle bladder cancer specific biology, but perhaps we are ready to target alterations in bladder cancer that are at least more common in this disease than other diseases. So what I'm going to focus on is FGFR3, HER2, KDM6A, and then PPAR gamma, and I would highlight that all of these targets are more common or enriched in luminal-like bladder cancer, which tends to be less responsive to chemotherapy, so there might be an added benefit of being able to use therapies in these patients who don't respond to other therapies. So FGFR3 is a really interesting gene. In 1994, there was a paper that described FGFR3 mutations in the germline, and when these mutations occur in the germline, they cause the most common form of short-lived dwarfism, achondroplasia, and the reason that this happens is that FGFR3 mutations inhibit chondrocyte proliferation in the growth plate. It was only about 5 years later in a paper in Nature Genetics that FGFR3 mutations were shown to be present in urothelial cancer. But then with additional study of FGFR3 in bladder cancer, there were a lot of complexities. One was that this is present much more commonly in low-grade disease, in fact, present in papillary low-grade bladder cancer, non-muscle invasive disease, which behaves very indolently. So you have this target that is present more commonly in low-grade, low-stage disease, and when it's present in the germline, actually inhibits cellular proliferation. So is this going to make a good therapeutic target? And there were a lot of questions about that. However, in cell culture and model systems, inhibition of FGFR3 met all the prerequisites for moving forward into the clinic. So there were attempts to bring this into the clinic, and unfortunately this was even more complicating because the first generation of drugs that were billed as FGFR3 inhibitors were not very potent, And so Matt Malowski led a phase 2 trial, really nice design with dovitinib, which is a multi-targeted tyrosine kinase inhibitor with FGFR3 inhibition. And that trial enrolled 2 arms simultaneously, an arm with wild-type FGFR3 mutants, and an arm with wild-type FGFR3 and an arm with mutant FGFR3. A Simon 2-stage design was applied to both arms simultaneously. There was 1 response in the wild-type arm and no responses in the mutant arm. And so that led to, again, a question about whether or not this was a valid therapeutic target in the clinic. And then came the more potent, more selective generation of FGFR3 inhibitors. And it was clear pretty early on that in the clinic these were different. So here's one of my patients treated with BGJ398. You can see here January 2016, multiple lung metastases, 2 months on therapy, and these really disappear with the development of cavitation in sites of prior disease. So this is, oncogene addiction reminiscent of what we see with EGFR inhibition responses, right? Really providing some proof of concept for this target. The other thing that was different was the toxicities. And there are class-related toxicities with these drugs, hyperphosphatemia, and nail changes, skin changes, that weren't seen with dovitinib or other less potent FGFR3 inhibitors, which have been seen with every potent and selective FGFR3 inhibitor to date. And this is, again, one of my patients. And when we talk about nail changes, and you see this on CT-scan tables, you kind of brush it off, right? Nail changes. This patient lost all the nails on his feet. Really miserable pain. And so when we're dosing drugs chronically in this disease where we haven't before, we've generally given chemotherapy, immunotherapy, not oral drugs given daily. This is an older patient population. It is something that I think is going to take a little bit of education. So there are a number of potent and selective FGFR3 inhibitors which have reached the clinic. I'm just highlighting these 3 because there have been published phase 2 trials, or at least presented phase 2 trials, but there are molecules from Taiho, Incyte, AstraZeneca that aren't on this list. So BGJ398 is the Novartis compound which they've actually sold since the conduct of this trial. 67 patients enrolled. This was a biomarker-selected trial, so patients had to have hotspot mutations, or they could have FGFR3 fusions, which are less common but also activating. And you can see here an objective response rate of 25%, and that really has been shown with each of the FGFR3 inhibitors. Erdafitinib presented at ASCO GU this year with a response rate of 35%. That's a J&J compound, and then the Bayer compound, regorafenib, was presented at ESMO, and the one difference with the development of regorafenib than the others is that they are enrolling patients with increased FGFR3 expression at the mRNA level, and they actually have shown in some patients that have increased FGFR3 expression at the mRNA level, but not mutations, they've shown objective responses. And this isn't entirely surprising, as luminal bladder cancer is really enriched for both FGFR3 mutations and increased expression, and mutations do lead to increased expression as well. So everything goes back to immunology now, right? So Randy Swice did a really nice study in Tom Gajewski's lab, an in silico study. Tom Gajewski has published some very nice studies trying to define tumor intrinsic mechanisms that lead to exclusion of T cells as a potential way to identify targets that might be able to overcome a cold tumor microenvironment. And so Randy Swice did this study where he took the TCGA data and used gene expression-based surrogates of T cell infiltration, and basically took the hottest tumors and the coldest tumors and threw out the tumors in the middle, and looked at the differences in signaling pathways and specific mutations in the outliers, and showed that FGFR3 mutations were present predominantly in the cold tumors. Very nice study. The problem with this is that this is an association. This does not suggest causality. This data has really been left on first as a basis for combination studies, which are certainly fine, but also as a reason to potentially exclude patients from receiving immune checkpoint blockade if FGFR3 mutations are present. And I think that's an overinterpretation of the data. And when we've looked at this, I think my time's up there. Okay, so when we looked at this in the Checkmate 275 study, where we have whole exome sequencing data on the vast majority of patients prior to initiating treatment, you could see that patients with FGFR3 mutations, while a small subset, but a representative of the prevalence of this alteration, had response rates that were identical to the entire patient population. We've shown this in 2 additional data sets as well. So I don't think there's causality here. We know that luminal-like bladder cancer tends to be less immune cell infiltrated. We know that luminal-like bladder cancer also is enriched in FGFR3 mutations. This is an association. The real smoking gun, I don't think we've identified yet. I'm going to move a little bit faster here. So the other alteration that is certainly not unique to bladder cancer, but present in a high proportion of patients with bladder cancer is HER2. And not only HER2 amplification, but activating mutations in HER2 and HER3 as well. And these tend to occur in the kinase domain. And I think the question about whether or not HER2 should be targeted in bladder cancer with small molecules was really addressed nicely by David Hyman and David Solit in their paper published in Nature with neratinib. This is a beautiful study. I tend not to show figures that are this complicated in a talk, although the data visualization here I think is elegant. And so I had to show it. And what you see here is the presence of the HER2 alteration in terms of whether or not it occurs in the extracellular domain versus the kinase domain versus the transmembrane domain. You can see based on the size of the bubble how common those alterations were for these respective tumor types, and then the bubble is shaded depending on whether or not there were responses seen. So the clear bubbles are those with no responses, and the dark bubbles are those with a lot of responses. So you can see here that the extracellular domain is where the predominance of HER2 mutations were in bladder cancer. There were no responses in bladder cancer, yet there were responses in patients with the S310 mutation in breast cancer. So context does clearly matter here, and I think this might suggest that this is not a viable target in this disease. Notably, no responses in any tumor types with HER3 mutations in this study, despite their presence in multiple tumor types. So I'm going to skip here and finish up. So these are the most common mutations based on the TCGA in bladder cancer in terms of prevalence, and you can see that at least 2/3 of these mutations are chromatin remodeling gene mutations. So this is biology. There's biology here that is begging to be explored in the clinic in bladder cancer. I'm just going to focus on KDM6A because this is the most well-characterized. KDM6A is a lysine 27 specific demethylase. It's an eraser. It removes this trimethyl group from lysine 27. When this trimethyl group is here, this is a repressive mark. It represses gene transcription. And so when this is knocked out, and these are loss of function mutations, when KDM6A doesn't function, these trimethyl groups accumulate and they cause gene repression. EZH2 is a writer for this group. So you can imagine if you take out the eraser, then one could reason, what if you take out the writer here as well? Would that lead to some sort of synthetic lethality picture? And this has been explored in model systems in a very nice study from Bintay's lab. And here you can see in patient-derived xenografts in a KDM6A null tumor versus a KDM6A wild-type tumor, urothelial cancer, a tool compound EZH2 inhibitor shows selective tumor growth inhibition in the null xenograft with really no activity in the wild-type tumor. So the take-home here is that there are bladder cancer-specific targets that are now entering the clinic that are druggable. And I think in the near future, we might have some drugs that are really specific to bladder cancer biology rather than just taking drugs that have been developed in other diseases. I'll stop there.
Great talk, Matt. I think really the prime example that has come forth with these targeted therapies is what's going on with mTOR and PI3 kinase. Matt Galsky also, I think he was the main author on a trial that looked at, and actually they have one case where it was really, really dramatically, a patient dramatically responded to that. So there are other mutations that I think, in addition to what you were saying, TSC1, TSC2 is being targeted. VEGF, we're still waiting for Jonathan's trial to come out. Maybe someday it will. We'll have hopefully the results presented this fall from the range trial, which looked at ramucirumab and docetaxel. That came out in a press release that there was a trend towards improved survival, but not significant. So I think that there's a lot of room for targeted therapy in this area. Any other questions for Matt?